So what about the clinical trials that we do over at UCSF? Every medication, as you know, has its own side effects, and kidney transplantation is not perfect yet. Obviously, we need there's a lot more room for research and innovation in terms of new medications, new monitoring. So one study that I'm interested in, that I'm working on, is I want to know, how can I better monitor somebody's real level of immunosuppression? So right now, everybody is treated the same. So for the first 3 to 6 months, we all want a certain blood level of our medications in the blood for every single patient. So everyone gets, for example, a Prograf level of 8 to 12 for the first 3 to 6 months, everybody. But Mr. Smith might only need a blood level of 5 to 7 to prevent him from rejecting and minimize the immunosuppressive complications. And Mr. Jones may need a level of 12 to 14. But we don't know that until somebody presents to us with either an infection, which means that they've been over immunosuppressed, even though they're at the right level, or a rejection, which means that they're under immunosuppressed. So that's an active field of research, is immune monitoring. I want to look for other markers in your blood that tells me, you know what, this person is showing me signs they only need this level in their blood, and they're adequately immunosuppressed. So UCSF continues to be a world leader in new drug development. We have many new drugs on the market that we're looking for to avoid some of the toxicities of the current medications that we have. And obviously patient participation in our studies is crucial for the advancement of transplantation. So after the transplant, what can you expect? Well, we want to see you a lot at the transplant center. This can be very difficult, but the first month after your kidney transplant, we need blood work on you twice a week, and we need to see you in our clinic at least once a week. That's for the first 4 weeks. Why is that? That's when all the changes are happening. That's when you're getting used to your medications. That's when we can monitor your levels. That's when your blood pressure is changing. That's when your diabetes is changing. That's when all the acute issues are happening. And so we see you, we want blood work done on you very frequently the first 4 weeks. And that goes on, and then we taper it down, we see you once a week. And then we go to once every 2 weeks. And then we go to once a month. And then as you get farther away, we see you less and less unless you need to see us. But we do get lab tests still forever that we want to see at our institution about once a month. We want to make sure that you're taking your medicine properly. You're on a whole new bunch of medications. We want to make sure that you're taking them the correct way. And we want to make sure that you're communicating with us about any problems that you're encountering. So again, this is just a summary for the first week 1 to 4. We expect to see you or get blood work on you at least twice a week. Weeks 5 to 12, we want to see you once a week. 13 to 24, about 2 times a month. And then week 25 to 52, we want to see you about once a month. It's important to realize that 40% of patients do get readmitted to the hospital within the first 6 months. This is not uncommon, clearly, and it is expected. It's a whole new, like I mentioned before, it's a whole new world, and we monitor you very carefully, but complications happen, and there is a high readmission rate. And the reasons are for rejection episodes, for infections, and other kinds of complications. So, you want to know, when can I start driving? That's a major question that oftentimes I get after transplant. We usually say 6 to 8 weeks after your transplant, you could start driving again. We encourage our patients to go back to work 6 to 8 weeks after their transplant. Physical activity, 12 hours. We don't give you any time to take a nap in the hospital. Don't even think about it. We get you right out of bed immediately, walking around on the floors. We want you moving. Sexual activity when you're comfortable. And then vocational rehabilitation. So there are programs through the NKF and other government agencies for people who are interested in getting back into the workforce, and we encourage that. So while you're waiting on the wait list, if you don't have a living donor and you're listed and you're on the cadaveric wait list, we want to be updated. You are all assigned, you will all be assigned a coordinator, two of which we have here today, who will be happy to answer your questions. We want to know about your physical condition. We want to know if anything has changed over the years of waiting on the wait list. We do get periodic blood sampling sent to UCSF. So what's that blood sampling for? To show us, have you had any development of these antibodies that I talked to you about? Have you become sensitized, meaning for whatever reason, have you developed an immune response that may make it more difficult to get you a transplant? You're welcome to call us for questions regarding the status, where you are on the wait list. And of course, if you move or you change your phone number or your address, we need you to tell us, because clearly kidney transplants happen in the middle of the night. We need to be able to reach you when that transplant is available. So the cadaveric waiting list. So patients are placed both on the national and the regional waiting list. Patients are given kidneys from the same blood type or blood type compatible. As I mentioned, O is the universal donor. So O can give to anybody. And AB can get a B. They can receive from anybody. So it's really compatible blood type. And waiting time is influenced by the presence or absence of these anti-HLA antibodies. So again, you could be called in for a transplant. You're up on the list. Blood type is compatible. They do the cross match, comes back positive. That means that you can't get that kidney because you're going to reject that kidney. So that's why waiting time might be influenced for that reason. The minimum waiting times are long, unfortunately. Blood type AB, it's the shortest, again, because it can receive a transplant from any blood type. 5 years is the waiting time. Blood type A is 6 years, O is 7 years, and blood type B is 6 years as well. So if you have a living donor, so the living donor transplant is the best opportunity for the best quality kidney in the shortest possible waiting time. Donor benefits. We're going to hear a little bit about that after my presentation, but every donor gets a comprehensive medical evaluation. So a lot of times we hear, well, I don't want to put this person at risk. I don't want to bring this person in to be a donor because I don't want them to be hurt, or and I understand that. We don't take a kidney from someone who we don't think is a suitable donor. We do a thorough medical evaluation. We do blood tests. We do urine tests. We do CAT scans. We do everything to make sure that that donor is safe to be a kidney donor. Patients do benefit. Donors do benefit. They feel like they've given the gift of life. Oftentimes they've given it to a family member or a loved one or a friend, and they benefit from that donation as well to improve the health of someone that they love. And there's been studies that have shown improved self-esteem for donors. So again, our donor evaluations, we do a full medical history. ABO typing, cross-match. So with a living donor, we have the luxury of having them right there to be able to see, they take their blood and take their recipient's blood and see, is this a good donor for this person? Does this recipient have antibodies to this donor? We don't have to do it in the middle of the night. We can do a much more extensive panel to see what kind of reactivity we have between the donor and recipient. So we do the cross-match. We do a full physical exam on our donors, blood tests, urine tests, chest x-ray, EKG. We look at their kidneys, obviously. We look at the arteries to their kidneys. Again, we do a full donor evaluation. In addition, if you are thinking of coming forward as a donor, but you're like, well, I don't think I can be a donor because of a certain medical condition that I have, let us make that decision. You can fill out the forms. We'll let you know if what you have or your medical condition precludes you from being a donor. Our donors undergo a laparoscopic nephrectomy. So this is a very simple schematic: kidney in and then kidneys removed, and it's done laparoscopically. And these are the scars that you'll see. So these are the small, tiny little incisions. We do supply these very lovely Band-Aids, if you guys are interested. That they're very small incisions, which inserts the camera and the instruments that are used to remove the kidney laparoscopically. And then there's one larger incision, which is where the kidney is taken out. So the donor hospital stay. The surgery occurs on the first hospital day, takes 3 to 4 hours. Again, the donor is admitted to a specialized nurse, the transplant unit on 9-long. The hospital stay is about 2 to 5 days, and discharge really just depends on, are you eating, are you drinking, and how is your pain being controlled. Oftentimes the donors actually seem to look a little bit worse than the recipients after a transplant. So the donors, are the ones that we need to get out of bed and moving along, and the recipients are like, oh, I feel great, I'm doing fabulous, walking around the unit. So. What about donor complications? Well, again, similar to any kind of surgery, wound infection. That's like any kind of surgery. They may require a blood transfusion. They can potentially develop a hernia at the site of the incision. That just means that a small outpouching of the bowel kind of breaks through where the incision is. High blood pressure. So in terms of long-term medical effects of kidney donation, there is no increased incidence of chronic kidney disease in the kidney donor above and beyond the general population. So there's no difference in the development of kidney disease between the general population and someone who's donated a kidney. And that's because we cherry pick our donors. We pick our donors very carefully because we want to minimize their risk of development of CKD. So if they have any risk factors for CKD, we do not accept them as a donor. So it's very rare. Blood pressures may go up after kidney donation. Women who are of childbearing age who donate may be at slightly higher risk of development of preeclampsia during a pregnancy. But not enough to, but still a very infrequent occurrence. So what do we do with our donors? Well, we want them to, they usually come in with their recipients for their visit 7 to 10 days after discharge. We look at the wounds, we make sure they're healing well, we look at their kidney function, we look at their blood work to make sure that everything looks great. We get a second visit about a month later, and then yearly checkups. Their general doctor. So what are our special programs, okay? So the wait list is very long, as you saw before, ranging anywhere from 6 to 8 years. And that's for standard kidney donors, cadaveric kidney donors. Again, when we're talking about the wait list, we're talking about waiting for cadaveric donors. We have different programs, and I'm sure that the coordinators can go into more detail on them. But we have what's called the Expanded Criteria Donor Program. The way that I describe this is getting a used car instead of a new car. So basically, these are from cadaveric donors who are older. So someone who has passed away from brain death, who is older than 60 years old, is considered an expanded criteria donor. Someone who's over the age of 50 who dies, who has high blood pressure themselves, or other diseases that may predispose that person to kidney disease, is an expanded criteria donor. We offer this program to patients who are older than 60 or older than 40 with diabetes. So patients who are older than 60, instead of waiting for 6 to 8 years for a kidney, it cuts their wait time in half. So you can get a kidney from an expanded criteria donor in 3 years instead of 6 years. The kidney may not last as long as a standard donor, but older patients may opt for, well, I want to get a kidney earlier, than wait the full 6 to 8 years. We have certain weight cutoffs for our expanded criteria donor program, but it is an excellent program. We also don't take, clearly we don't take kidneys that are very damaged, are not expanded criteria donor. These are clearly patients who are older, but they have good enough kidney function that we think they're appropriate to transplant in our older patients. We have high-risk donor programs. So what's high risk? Well, High-risk donors are donors that have been incarcerated, donors that may have a history of drug abuse in the past. These are people who die and have participated in what's considered high-risk behavior. And so they may be slightly higher risk of having illnesses that we cannot detect, like hepatitis or HIV. So we screen all donors, every single donor, deceased and living, clearly for HIV, hepatitis B, hepatitis C. So we never take a kidney from a patient who's hepatitis B or hepatitis C or HIV. However, high-risk donors are considered to be slightly higher risk of having contracted that illness within the period of time, which is usually weeks, where we cannot detect it on our blood tests. That's what a high-risk donor is. To be honest with you, we don't really consider them significantly more high risk than a standard donor, simply because standard donors, oftentimes we don't have that kind of information, enough information about them. But we consider this a very low risk transplant, nonetheless, of contracting any of these infections. Hepatitis C donor program for our patients who have end-stage kidney disease and hepatitis C. We offer them kidneys from patients, from deceased donors with hepatitis C as well. And then living donor programs. So oftentimes, because we have the luxury of doing all these testing to look for positive cross matches between a living donor and recipient, we can see if someone's incompatible. So if, let's say, you have your donor, your friend or your colleague or your sister who wants to donate to you, but she is a blood type A, and you are blood type B, and she can't donate to you. We have paired exchange programs where we find another couple where the recipient is actually a blood type, A, and the donor is a blood type B, and there's a swap where you agree that because I can't donate to my recipient, I do match a blood type with that person's recipient. I can give to them, and they can give to my recipient. So that's the paired exchange program. We do have a desensitization protocol. So what does that mean? Well, if I have a donor who is compatible with blood type, but I have antibodies to her or him, and a positive cross match, under certain circumstances, we will give you medication, the recipient medication, to try to get rid of those antibodies before the transplant, to clear them, and then proceed with transplantation. That's the IVIG program for patients with antibodies, and that's with living pairs. We do have a blood type ABO incompatible transplant program, so that if you can't go into the paired exchange, we, under some circumstances, very limited, we will transplant over a blood type barrier. So in summary, kidney transplant is more than just having an operation. It's a partnership between the transplant center and you to keep you and your kidney healthy. Thank you. I'm happy to take any questions.
If a person has rheumatoid arthritis, which is already a very bad immune suppressant disease, and needs a transplant down the line, does that affect the ability, they're being chosen to have a transplant?
No. If the question was, if a person has rheumatoid arthritis, which in and of itself, that oftentimes they're placed on a lot of immunosuppressive medications and become very immunosuppressed, does that become a contraindication to transplantation? And the answer is no. We have several patients with autoimmune diseases, lupus, and others who are on immunosuppressive medications for a long period of time. It is certainly not a contraindication to transplant. We transplant these patients frequently. Yes?
My understanding is when you have a damaged kidney, you get anemia because your damaged kidney cannot produce something to create the blood red
That's right.
cells. However, after a transplant, why are you?
Where it is a transplant floor. The nurses are trained in transplant. You'll see their kidney transplant, a hormone that's made by the kidneys. When the kidneys fail, they can no longer make that hormone, and so several patients are dependent on Procrit, EPO, Epogen, Aranesp, what they get with dialysis, to help to give back that hormone. That's a very good question, and it's multifactorial, the answer to that question. First of all, some patients go the opposite way and become the opposite of anemic. Their new kidney is producing so much hormone that we oftentimes have to take blood out of them because their blood counts are too high. A lot of our medications suppress the bone marrow. So they suppress the immune system, which also suppresses the red blood cells, and they become anemic because of some of the medications that we're giving them can suppress the bone marrow and cause anemia for that reason. So that's an excellent question, but it's multifactorial. Usually it's related to our medications that can cause anemia.
But then does the new kidney produce this hormone then?
It does produce this hormone, but frequently we do still maintain patients on EPO or Procrit if they are anemic after transplantation. Yes?
When you're transplanting, do you still use a high bolus of steroids? Is that the regimen right now, the protocol?
Yes, the question is when you transplant, do you still use a high bolus of steroids? And the answer is yes. Usually for the first 3 days, we start off with 500 milligrams of Cytomedrol, then 250, then 125, and then you get sent home on a taper, and you're maintained on 5 milligrams of prednisone. We do have steroid-sparing protocols. It does not mean you don't get the bolus, but it means you're maintained on immunosuppressive medications, but not including prednisone. But these are for patients who are very low risk for rejection. Prior kidney patients who have been exposed, who have antibodies, who are prior kidney transplant patients, are maintained on steroids because they are at higher risk of rejection of the new kidney. But we do bolus all patients with steroids at the beginning. Yes?
You mentioned the national and local waitlist programs.
Yes.
Does that mean there are wide differences between states and regions for particular blood group types?
There is different waiting times between different regions. I am going to have those questions answered by the transplant coordinators because they're very knowledgeable about the lists, so they'll help you out. Do you guys want to answer that question actually?
Yes, actually the waiting times that Allison told you about are within our Northern California region. And in other parts of the United States, there are different waiting times based on the donor and the recipients in that region. So there are some patients pending their insurance authorizations that may be listed here in California, in Northern California, and then also in another state, just to increase the amount of donors that they're exposed to and also potentially decrease their waiting times.
Thank you.
It's very important to note the United Network of Organ Sharing UNOs does require all transplant centers to let the patient know that you can get yourself listed in multiple areas. However, it is important, just like Linda just indicated, your insurance company doesn't have to pay for you to get multi-listed. All insurance companies differ. And I encounter this as a manager quite a bit, where that UNOS pamphlet gets misunderstood by patients. You have the right to multi-list, however, your insurance does not have to pay for you to multi-list in other areas. So you can list here with us at UCSF if you want to go to even UCLA, or you want to go to Texas, or wherever. That's a private conversation between you and your insurance, whether or not they're going to pay for that. But you can do that if you're self-pay.
Thank you.
Other questions? Yeah? Oh, I'm sorry. Yeah, go ahead.
What is involved then in transferring, apart from what you just said, what's involved in transferring from, let's say, Stanford to UCSF if you're not completely happy with the follow-ups at Stanford?
I was going to say that certainly couldn't apply to UCSF, so that makes a lot of sense. Okay. Go ahead.
Right. I will speak to the insurance piece of it. Number one is your insurance company, depending on what type. I mean, I can go hours on insurances, which I will not do that. But if you have an insurance type where you have a specific contract with a specific center, i.e. in this scenario, Stanford, you as a patient, if you're unsatisfied, need to go through a process in order to ask that insurance company to make you the exception to that contract. That, unfortunately, is not something UCSF can help you with. That is something where you would need to handle within your insurance. And then once they say, okay, here's your authorization, you can transfer to UCSF, then you would contact our center saying, I would like to transfer my time to UCSF, I need to be scheduled for an evaluation appointment. And then at that point, the team would step in just as though you were a brand new referral to us, because again, as Dr. Weber indicated, what UCSF's process are not necessarily in the same similarities as Stanford, so their criteria and our criteria is different in some ways. So sometimes as a manager, I get the question, why do I have to do this extra widget? And I'm like, because welcome to UCSF, we want that widget. So, and then I transfer you to the coordinator and say, you explain it to them, because I am, of course, the business financial piece of it, and I definitely refer the medical component to the appropriate parties.
And let me just make one other comment with respects to that. When a patient does transfer from one center to another, whatever time you already have accrued on the waiting list at the original center can be transferred through the signature. So you would not be starting over because you went to a different transplant center. You can transfer that waiting time from one center to another.
Yes?
I'd like to know that if you transfer, it's not like you're leaving one and going to the other. It could be multiple ones, right?
With some insurances, yes, you can multiply list within a region. Like in the Northern California region, there's Stanford, UC San Francisco, and California Pacific. Within those three institutions, if your insurance allows, technically you can be listed at all three, but you will only have one, or your original list date will only be at one center. And since in this region, when there are organs in this region, these three independent institutions, we draw our individual lists together for one master list. So whether you're listed on Stanford, UC, Cal Pacific, the organ is going to the institution that has the patient that's compatible with the most waiting time and that is medically suitable.
Okay.
Quick question. Referring to this sweet lady's question about having rheumatoid arthritis and the donation process, if it was reversed and a living donor has rheumatoid arthritis, is that something that would stop them? Or?
No, what I always tell every donor is fill out the paperwork, we'll do the assessment, we'll make a decision. There's really, that's what I encourage. So it's really based on an individual evaluation and on an individual basis.
Okay, thank you.
Yes.
I'm listed there at UCSF, and my antibody level is 98%. What would be the protocol for how many HLA matches do I need? Do I need all 6? And if, how does that work? And then would I be getting IVIG?
Okay, so it doesn't matter how many matches you have, as long as you don't have antibodies against your donor's HLA. So if you are matched at none of the different loci, like there are 6 spots, okay? If you're matched at none of them, it doesn't really matter as long as your PRA is not reflecting that you have antibodies against whatever their HLA is. So you might luck out and get a completely not matched kidney, but you just don't happen to have antibodies to what any of their HLA is. So it doesn't have to, a perfect match would be fantastic. I mean, that would be excellent in your situation, but you certainly don't have to have a perfect match. You just have to make sure you don't have antibodies against that person. We can't tell until the offer comes. Do you see what I'm saying? IVIG we give for our living donor pairs only. Yes.
How is it determined when a candidate comes in for initial evaluation? Is that up to the nephrologist that one's seeing, or can you self-refer for evaluation?
Yeah.
And another question is, are there age limitations for transplant?
Okay. So for the first question is, who determines when one can be sent for an evaluation for a kidney transplant? Can you self-refer? Does your nephrologist have to refer? When your nephrologist has to refer, we have certain criteria. Either when you're on dialysis, you're ready to be evaluated for a kidney transplant, Or if what's called your GFR, which is your glomerular filtration rate, which is an assessment of how well your kidneys are functioning, drops below 20%, that's when you can be evaluated. If your GFR is over 20, you are not ready for a kidney transplant evaluation. Anything else you want to add to that? There's a referral? No.
We can see you for an evaluation, but you wouldn't gain time on the waiting list. If your function is over 25, then you're really too early to be evaluated. But if it's below 25, we can see you, but you'll be in a hold until your function goes below 20. And you would have to notify us when that happens.
And the age limitation?
There is no age limitation. Every patient who is over the age of 70 gets presented to a committee. It's called a selection committee of transplant surgeons, physicians, nurse coordinators, to decide whether that patient is over 70 is fit to be a candidate. But we transplant patients over 70 all the time. Yes.
Is polycystic kidney a greater detriment to a transplant than other kidney diseases?
The question is polycystic kidney disease more of a detriment than other diseases in getting a transplant? And the answer is absolutely not. And in fact, patients who have polycystic kidney disease do very, very well with a kidney transplant. So, no, we love our polycystic kidney patients. Yes, we love everybody. We love everybody.